Very good evening to all. It's such a pleasure to be here. It's been less than a year since we acquired the Mantra 3 robot, and we have already performed more than 125 surgeries, and most of them, because I have been a fertility specialist, most of them have been fertility enhancing robotic surgery. Now, infertility is something which is growing at a very rapid phase, and unfortunately, somewhere we have started equating infertility with IVF. So even patients feel that if they have infertility, the way to go is IUI or IVF, and many of us, even as gynecs, neglect this very important part of pelvic reconstruction, of uterine factor infertility. And as a unit, we have always felt that unless your reproductive surgery is very good, you cannot really expect great outcomes when it comes to your IVF or IUI cycles also. The big advantage that I have found in robotic surgery, we have been operating laparoscopically for a very long time. But I think, as you saw in today's recanalization, the wristed instrument, that has been a game changer when it comes to recanalization. This is one surgery where I think it definitely scores in a big way over laparoscopic recanalization. And the second one, which we are eventually understanding, is fibroids which are very near the endometrial cavity, and also the posterior parametrium and the endometriosis cases. The largest number of cases in our series has been myomectomies. We all know that if a patient harbors a fibroid which is submucous, that always needs to come out, and more often than not it is removed hysteroscopically. But if it's a type 3 fibroid, that is, it is straddling the endometrium, straddling the myometrium, touching the endometrium, these are challenging fibroids because sometimes they may not have a serosal indentation and you may not even be able to figure out where they are. Especially in fibroids where the endometrium is close to the fibroid. So for example, this fibroid, it's just a 3 centimeter fibroid, but what I'm cutting and what I'm leaving behind is actually the endometrial cavity. In laparoscopy also, I would have been able to spare the endometrial cavity, but the kind of magnification and the joy of operating contralaterally what we get in robotic surgery, I do not find it in the laparoscopic surgery. So the bulge that you see down is nothing but the endometrial cavity, and it is completely intact. Definitely sometimes we do end up opening the cavity, and it is said that it does not make a difference. But I would like to believe that the endomyometrial junction, which is very crucial to embryo implantation, we cannot imagine that you open the endometrium, you suture it back, and the results will be the same. So this is one case where we can beautifully appreciate that a type 3 fibroid removed completely without opening the endometrial cavity. Another example of finding beautiful planes, I think gynecology is mainly about finding the right planes. And before I did this surgery, I debated with myself that for such a small dermoid cyst, should I even be docking the robot and taking the whole trouble? But as we went along, you can see that we are able to figure out a very beautiful plane in robotic surgery. And I think the magic is in the monopolar scissors. This is the instrument that I have grown to love. We have hardly ever used monopolar energy when we were doing laparoscopies. But this scissor is such a versatile instrument. I don't even like to call it the scissor, it is like a paintbrush. It gives you such a beautiful delineation. Fiber by fiber you are able to open and reach the right plane, and there you go, the entire dermoid cyst, we have removed it intact without opening. Now we have done close to 30 dermoid cystectomies, and almost in all cases we have been able to remove the dermoid cyst without spillage. Again, of course, spillage is not a big deal. Even if you end up spilling some of the contents, it doesn't matter. But I would like to believe that when you get into the right plane and you don't do too much of suction or irrigation, it actually improves the patient outcome. This patient went home the very same day. Robotic tubal recanalization we have just seen, although it was not a very ideal case. In this patient you can see that the anastomosis was a little distal. So the proximal end was longer, and in such cases there is a little bit of luminal disparity, which we try to avoid by doing something called as fish mouthing. So we try to make the smaller lumen bigger by fish mouthing it. once we excise, I think the game changer suture is the one at 7 o'clock and 3 o'clock. These were extremely difficult to take by straight stick laparoscopic instruments, especially because all of us, most of us gynecs are ipsilateral surgeons when it comes to laparoscopy. Robotics gives us that advantage of sitting comfortably and doing a contralateral surgery. I always like to take two layers. So after taking mucosal sutures, seromuscular sutures, and the end where you see dye coming out nicely from the fallopian tubes. Now, other than these few surgeries, there are many situations where we actually need to remove the tubes. And more, as we see cases of hydrosalpinx, we see cases of pelvic inflammatory disease. Many times, tubal surgery has to be for removing the tube. But the problem is that when you remove the tube, which is in a tubo-ovarian mass, sometimes you might end up jeopardizing the blood flow to the ovary. And so, more often than not, whenever we see a patient with hydrosalpinx, we often post her for a robotic surgery, because in case the tube is repairable, we are able to do a robotic salpingostomy. In case it is not repairable, we are able to preserve the ovarian blood flow accurately and remove only the damaged fallopian tube and not the ovarian blood supply. This is a video of interval cerclage. Some patients have recurrent second trimester miscarriages and they go for vaginal cerclage, that is McDonald or Shirodkar cerclage. But in cases where they have failed a Shirodkar or a vaginal cerclage, we have to do a laparoscopic or a robotic cerclage. Now this can be done in pregnancy and this can be done as an interval procedure. This is a patient where we are doing an interval cerclage robotically. It's not a very difficult procedure, but I think very soon we will try and attempt a robotic cerclage during pregnancy also. I think with the centralization and with the contralateral approach, we'll be able to replicate these exact steps in pregnancy as well. So the steps are very simple. We open and we make a avascular window in the broad ligament, insert the tape and tie it at the level of internal os. This tape can be removed during delivery, or sometimes we like to leave this tape as such. So the trick is that you don't pierce the wall of the uterus, you just go medial to the uterine vessels without piercing the pedicle. Now this Marcelline tape is tied anteriorly. After this, the patient tries to conceive and this tape stays through pregnancy. Now, does it make a very big difference? Well, I would not say it does, but yes, at least in laparoscopic tubal recanalizations it does. This is an interesting case, not exactly a fertility sparing surgery, but this patient had a cornual ectopic pregnancy. She came to us, a very vascular, very angry looking mass, and the tube was distal to it. Now in this case, there is no way we can preserve the tube, and we injected vasopressin. And the whole point is finding the right plane. You see that I am not in the right plane now. Once I go in the right plane, again figuring out the right plane is very easy with the judicious use of the monopolar scissors. The entire vascular mass will pop out and we will be suturing the cornu. So there you can see the entire pregnancy and the placental tissue. If we are in the right plane, it all comes out very well. There is no point in preserving this tube because the pregnancy is in the intramural part of the fallopian tube. So the salpingectomy has to be done for this patient. And then we suture this cornu. Patient has to avoid pregnancy for 3 months and then she can plan for a pregnancy again. Here, because we were in the right plane, we have removed very little of the myometrium. So I have taken you through a short bird's eye view of what all is possible with robotic surgery when it comes to fertility enhancing surgeries. I think more and more we are adapting to it. The way ahead would be to integrate robotic surgery in a better way with hysteroscopy, because hysteroscopy and laparoscopy go together. With modular arms, we sometimes find it difficult to have the vaginal assistant do the manipulation, and these are, I think, all the experiences which we will get when we sit together and do more and more cases. Thank you so much for a patient here.